Our final speaker this morning is Miriam Kuppermann from the University of California, San Francisco, communicating about randomization with research participants.
Thank you and good morning. So I'm going to be focusing a little bit on the patient side, which is what I do research in. And what I've been asked to cover today is how we can better communicate to patients what it means to be randomized. So I'm going to be focusing my talk on 3 questions. First, I'll be talking about how is randomization described to patients or study participants, and both how it should be described and how it actually is described. Then I'll talk to you a little bit about what some of the studies have shown in terms of what study participants understand. And then I'll close with some suggestions about how it might be improved. So how should randomization be described to participants? Well, the World Health Organization notes that in a clinical trial involving randomization, participants should be told what randomization means and what chance they have of getting which drug. And suggested language from their template includes, quote, "We will put people taking part in this research into 2 groups. The groups are selected by chance, as if by tossing a coin." In this country, the National Cancer Institute recommends language such as, "A computer will by chance assign you to treatment groups in the study. This is called randomization." And by way of explanation, this is done by chance because no one knows if one study group is better or worse than the other. And that's right off their website. At my own institution, UCSF, the IRB clearly stipulates that randomization should be described as a study procedure. And then they recommend that terms not familiar to the average layperson be defined by saying things like assigned by chance rather than randomized, group rather than harm. And then they also suggest that the probability of assignment to each of the treatment is presented in words such as you have a 50-50 chance of being assigned to either group. So that's what's out there. And then the next step I did is to try to understand how it actually is described. And so I thought I should start with my own consent forms. Now, I have to say that I do research in informed decision-making for women of varying literacy levels, so all of my effort is dedicated to things like trying to explain chance and outcomes in the context of a decision tool. So I have to confess I was very chagrined because I hadn't looked at my consent form probably in a long time. And what it states is at the end of the interview, you will be randomly assigned to one of 2 groups. And then each group will have a different approach of blah, blah, blah. So no mention of chance, no description of the chance of being assigned to a group. And the only thing that actually we did right was to call it a group rather than an arm. And I do want to state, someone asked me, yes, these are all IRB-approved protocols and IRB-approved forms, so I wasn't getting away with or sneaking around them. So I asked friends and colleagues to send me some language about how they describe randomization in their consents, and I got a smattering. Most were quite similar to ours, meaning not much information. The first added, you will be randomly assigned to a group, and you cannot choose your group. Another one stated randomization means that you are put into a group by chance, so at least there's the explanation. And probably the best one I received was, a computer program will place you in one of the study groups. Neither you nor your study doctor can choose the group you will be in, and you will have an equal chance of being placed in either group. Now, those are all from studies that are not comparative effectiveness studies or standard of care studies. I did find one study that's ongoing in my department of obstetrics and gynecology, and I'm the vice chair for clinical research in that department, so I'm sort of have broader awareness of everything that's going on in the clinical research realm there. This is a study that's being done of 2 medications for pregnant women. And in the background materials on the consent, it notes that recent studies have found 2 medications that the 2 medications are effective, and that these medications are commonly used and are standard of care at our institution, and that there are limited studies comparing these 2 medications directly. When it came to randomization, the language says you will be assigned to a study group by chance, like a coin flip, rather than by a medical decision made by the researchers. So it's interesting, and not by your physician, but by the researchers. But again, no mention of the numerical chance of being randomized to each group. So now I'll shift to what participants understand. As I'm sure many of you know, there's an extensive literature documenting concerns about lack of understanding of informed consent. But most of that literature has focused on understanding of the risks of the interventions, the voluntary nature of participation, the reasons for refusals of participation, but there's been less focus on randomization per se. So one survey of the American public found that only 22% really understood what the word randomly meant, and many interpreted at random to mean without purpose. In a study of 130 students and adult learners in England, the participants were presented with a number of different allocation scenarios, and they were asked to indicate whether they thought those were random allocations or not, and if they were random, whether they felt that that would be acceptable to them if they were invited to participate in a clinical study. So most did understand that a computer with no information about the participant, a coin toss, or printed slips in a hat were random allocation methods, and most understood that asking each person what they would prefer is not random allocation. But there was a real split in understanding about allocation as they arrived, with half thinking that that was random allocation. But amongst these, the only one that was consistently rated as being acceptable to participants was the first one, the computer allocation. And it was exemplified by this quote: "I wouldn't want to think that my doctor had decided what to do by flipping a coin, and yet I have no problem with a computer doing it." Okay, but so what do actual patients or study participants understand about randomization? So one study about patients in a medical oncology clinic found that 31% of these patients did not realize that study participants are allocated by chance in a randomized trial. And nearly 3/4 thought that the doctor would always ensure that they received the best treatment for them. So this is sort of a confusion that persists. In another very impressive qualitative study of parents of patients, pediatric patients with leukemia, Kodish and colleagues, they taped what they called the ICCs, the Informed Consent Consultation, between patient and providers, and the mean length of these consultations were 79 minutes. So these were not brief encounters. And they did qualitative analysis and did find that 83% of the physicians did mention randomization in that consultation. However, only 50% of the parents actually understood what randomization was, and perhaps not unexpectedly, those of lower socioeconomic status and lower educational attainment were less likely to understand it. And disturbingly, those who did not understand randomization were actually more likely to enroll in the study. Sorry, not his study, but the clinical trial that he enrolled in. Okay, so let's talk for a moment about lower literacy populations, because again, that's sort of a given that people with lower literacy are going to have less ability to understand informed consent. But I do want to start by saying that this is not some sort of special case or bit of esoterica. So in a survey of the U.S. population, 20% of U.S. adults were found to be functionally illiterate, and another 27% had marginal literacy skills. And when we're talking about doing a comparative effectiveness studies, we want diverse populations. We want populations that are representative of the country. So this is not, as I say, a bit of esoterica. So, Terry Davis, who does a lot of work in health literacy, did a study in which she took a consent form that was being used by oncology clinics in her area and made it more accessible for lower literacy participants. And there's sort of standards for that, using less complicated language, less words, more graphics. And so there were two versions, the LSU version and the standard version. I'm almost. So the mean realm scores, and realm is a measure of health literacy, was 50 in the population, and that's equivalent to about a 7th to 8th grade level, and 25% were in fact marginally literate. And of those who are marginally literate, 70% did say that they preferred the LSU form and they thought that it was easier to read, but sadly, no difference in comprehension. So more recently, actually this year, a review was published of participant comprehension of research for which they volunteer. And this was about all aspects, not just randomization. So it was a systematic review of 27 that met inclusion criteria. And from this review, the authors concluded that there is a continued lack of understanding of randomization among research participants. And this is a quote, "Even when consent form language was simplified, 3 aspects of informed consent were particularly difficult for participants to understand: blinding, randomization, and placebo." So how can we improve understanding? Well, a systematic review that was actually published about a decade ago in JAMA found 12 trials of multimedia interventions, and multimedia is often proposed as a way to make things more comprehensible. Unfortunately, all but one failed to improve understanding, and the one that was effective was for patients with psychotic disorders. They also found 15 trials of enhanced consent forms with more mixed results. However, 6 did show significant gains in understanding, but 9 did not. And unfortunately, 4 of the 5 most rigorously designed studies showed no effect. And they did, there was evidence to suggest that person-to-person contact may be more effective, but as you recall, with an average consultation of 80 minutes, there still wasn't a lot of success at explaining randomization. So now I'll just close with some of the visuals and some techniques that people have recommended. So I do, as I have mentioned, I do develop decision aids. And in the decision aid community, we've spent a lot of time talking about how to display chance and risk in ways that are accessible to patients. So this is an example from one of my tools. It's for women considering prenatal genetic testing. It's to display the 5% chance of a false positive result from screening. So this is the pictograph we use. And we have tested these in adults of lower literacy. Here's something from the CISNET website showing randomization allocations. And another one from NIMH. So pictures are out there. We still don't know whether they improve understanding. There's some suggestion that group information sessions might be helpful. There was one paper published on that, and I know that certainly in pregnancy there's a lot more group counseling centering for pregnancy, so the group idea is an interesting one. Again, people propose more in-depth counseling, but I just wonder, 80 minutes is already pretty in-depth, and others that I'm sure are out there. And the implications for standard of care studies, I'm really not quite sure how it differs. Thank you.
Thank you. Questions?
Great talk. Thanks, John Lantos, Kansas City. I mean, it seems like we know now that no matter how hard we try, it's really difficult to explain randomization. And we seem to know that we can measure whether people understand randomization or not. All these studies say so many understood it, so many didn't. Would it be a good idea to just say you have to take a test, and if you don't understand randomization, you're ineligible for the study?
So
that could be for anybody on the panel.
Okay. Well, I'll take a first stab. And I would say I would hate to think that was the case, because then we'll again get a much more homogeneous population. We won't get the diversity that we absolutely need in the samples to make it generalizable to our country. So that would be a no vote for me. Thumbs down.
Ruth Macklin, Albert Einstein College of Medicine. One thing still isn't clear to me, and that is, with all the statistics and all the studies, is it the case that people still don't understand randomization when these other terms are used? In other words, if they say like flipping a coin or the computer will choose or any of these others, do people still not understand, or is there a spread whereby people understand less when the word randomization is used or randomly is used than they do in these other examples?
Okay, so I have not combed that detail in the literature. I don't know if those studies have been done. So I can just say that I did come across studies talking about how participants or people react to these terms. So some people, flip of the coin is often advocated, but there was a group of women in, I think it was West Virginia, and they didn't like things like flip of the coin, casting the die, chance, lotteries, because that all implies gambling to them, and that's not the way they view things. So, so people are going to interpret things different way, and so that's all that I can say. But I agree. Those are.
Let me ask one other question, and maybe it may be something to do after the break. We all rely on cognitive measures. That is, do people understand particular terms? But having studied cognitive failures in other domains, I think this has less to do with literacy, IQ, and so forth, and much more to do with attention. I bet most people here, when they get to contractual language, whether it's clear or unclear, zone out. And I wonder whether anybody is measuring attention, metacognition, engagement, emotional engagement, as opposed to whether people understand particular words. I mean, in some ways, it's just the next question after Ruth's about understanding. It's what other factors might impede taking the information in besides just literacy.
Yeah, so I think, and that's part of the argument that people have made to really simplify the forms. They're so long that no one gets anything. But there's another thing that I think in my reading, that there's this sort of cognitive dissonance almost, the idea that even though they know they're being randomized, there's still a feeling that somehow, though, the doctor's going to think about what's best for them.
But that goes to irrationality, not to lack of literacy. So I think we should come back to that later. And thank you. I didn't make up any time, sorry, but these were wonderful talks and questions. So let's, so that we can be attentive, let's take a 15-minute break, 10-minute break. Oh, the staff is tough. A 10-minute break, and let's be back at 5 minutes before the hour.